Hi, thanks very much for having me. It's very nice to be back on home soil presenting some of the work that I did as part of my PhD here as well. So today I'm going to be talking about embracing variability in psychiatric disorders, but really I'm giving quite a primer into what normative modeling is. And then these guys will walk you through some really nice examples and applications. But before I dig in, I'm going to start with an analogy that I used through most of my PhD, and because I'm back on home turf, it feels appropriate. I'd like to introduce you to Kevin. Kevin was one of my supervisors, and if you look closely, you can see that he has brown hair, glasses, a beard, and brown eyes. If we dig a little deeper, you'll also find out that he likes cats and Star Wars. Let's call these the observable signs and symptoms. Okay, now perhaps there's another Kevin in the room, and if not, you can probably recall a couple of celebrities named Kevin. If you look closely, we can see some similarities, and yet they are also vastly different, but we still call them Kevin. All right, we might even be able to put together some set of criteria where if someone meets the minimum number of this, we call them Kevin. However, we can also appreciate that if we try and group all the Kevins into a single category, lots of information is lost. Kevin might not even look like Kevin anymore. And so this really provides the framework of why normative modeling is really important, because the question is the mean really representative of the individuals that we're looking at with psychiatric disorders? Particularly when you think of the most widely used experimental design, which is the case control comparison, where you have a group of controls, typically brought in with the absence of a psychiatric disorder, and then you've got a clinical cohort, such as those diagnosed with schizophrenia. You then compare the group means across a range of different brain regions to see what the difference is between cases and controls. However, like my Kevin example, the group mean really ignores this variability that we know that exists in psychiatric disorders. In fact, the clinical cohort might look a little bit more like this. They're much more blurred, and perhaps they even might blend in with the control group based on some variables. So this brings us back to the question of, is the mean really representative of individuals? And if we zoom back and think just how psychiatric disorders are diagnosed, it's not surprising that this variability exists. If you look at the diagnosis of depression, for example, in order to meet the diagnosis, you have to have 5 or more of the following symptoms. So it's possible that 2 individuals might have very few overlapping symptoms. And this just is based on their clinical presentation or diagnosis. But this is not the only variability that exists. There's a whole range of other factors that would also contribute to this variability within the context of psychiatric disorders that are missed when we look at this group mean approach of just looking at a group of people with schizophrenia, for example. And so normative modeling provides a really nice tool to understand and map this variability. The basic intuition behind this approach is that instead of you have a case and control group, for example, and you pull out a reference cohort, which is typically those from the general population. And then you can make estimates from this general cohort of whatever clinically relevant variables, such as gray matter volume, as a function of age and sex. And so within the reference cohort or the general community, this tells you what is the typical gray matter volume for a given age. This is exactly the same as perhaps what you've seen on the back door of your doctor's office of the standard growth height chart. And then once you have this reference sample, you can then make predictions about individuals within this clinical cohort. And so for this particular example here, this individual within this given brain region has lower gray matter volume than what you would expect by chance, based on the normative expectations. This is done for every single region in the brain or whatever the resolution that you're looking at. And so you have this Z-score deviation map, which tells you for any given brain region how much they deviate from this normative range. This can be done for every single individual with the basic assumption that people with a clinical diagnosis are likely to fall outside of this normative range, but the way in which they fall will vary across individuals. So based on the deviation Z-score maps here, the blue indicates lower gray matter volume than what you would expect by chance, not by chance, based on the normative expectations, and then the blue indicates higher gray matter volume. And so maybe it's longer than the decade, but in the last decade, there's really been an explosion of all the applications, both methodological and the clinical applications of normative modeling. It's been really exciting for me as an early career researcher to kind of fall in at this time. And I wanted to spotlight some of the cool studies that are happening by looking at the OHBM portal. But there was so many, and it was actually so exciting to see all the different applications of normative modeling within this conference, just compared to maybe 4 years ago. So instead, I'm going to just highlight a couple of things that I really think have led to this explosion, and then the wonderful people here will give you some really nice examples as well. And so for one of the reasons that I think this has really exploded is because of the scalability and the accessibility of the tools that are now available. I think Paul Thompson in the Telerak lecture did a really nice example of showing the value of open science and sharing large consortium data and the power that that can do. And alongside that, we've seen many methodological advancements. And in fact, we've seen 3 huge tools that have been developed that mean that you don't really need a large sample to look at normative models. You can apply these existing normative models to your own cohort. In particular, there's the PCN toolkit by Andre Marquand and those at Dondas Institute. There's also the brain charts and the centile brains. The centile brains, I think, was referenced also in Paul Thompson's talk based on the Enigma cohort. Okay, so I've shown you what a normative modeling is, but I want to show you just a brief understanding of what a basic application is or some of the very early applications. And so like I showed you, you can get a deviation Z-score map, and what was commonly done in some of the earlier studies, and I think what is still being done, is that you often apply a threshold to give you these extreme deviation maps. And the idea is that these extreme deviations perhaps may be clinically relevant or clinically meaningful in some way. And so some of the earlier studies was just really categorizing how much variability there is within a psychiatric disorder. And so these early approaches really just tried to categorize this by looking at the overlap between individuals. And so one of the first studies in this space, I think, was done by Thomas Wolfers. And so what I'm showing you here is on the top row, it's the percentage overlap of extreme negative deviations, so lower gray matter volume than what you would expect, than normative expectations. And then the bottom is the percentage of extreme positive deviations, so higher gray matter volume. And I think the take home that I want to give everyone here is that the color bar doesn't exceed 10, and so this means there's no greater overlap than 10% across individuals with a diagnosis of schizophrenia. I don't know about anyone else here, but when I first saw this paper, I was really surprised and quite shocked, considering when we think about most of what we know about biological psychiatry is based on these group mean approaches, and that might not even be representative of 10% of the people in the cohort. During my PhD, I was fortunate enough to work on normative modeling, extending this approach across a range of different psychiatric disorders, both in gray matter volume and white matter volume. And the takeaway again here is it doesn't matter which disorder we looked at, it was really hard to find overlap or consistency across individuals with the same diagnosis, with the overlap never exceeding 5% across any of the disorders. And so a question that I keep coming back with is like, what do we do with all this variability? How do we derive meaning for this? Like, we know that there's this widespread heterogeneity, but what can we do? And so since some of the early studies that have really just focused on categorizing what this variability is, we've seen an expansion of a whole bunch of studies looking at subtyping, stratification, looking at treatment outcomes and predictions, which we'll see a little bit of today, and then seeing how we can bring in other things about not just the brain, but these other bits of variability that we see within psychiatric disorders. That's my time. And so in particular, I've been thinking about variability across scales. This can mean a whole range of different things, but we know that the brain is a connected network, and there's a whole bunch of different scales that we can think about variability. And so during my PhD, I thought about this in the context of looking at the networks within where these regional deviations lie. And so not just looking at the individual regions, extreme deviations in given regions, but also looking at the extended structural and functional networks. And the take home here was what I found was that these deviations that I looked at aggregate within common networks and circuits, but it never exceeded 60%. So even when I zoomed out a little bit to look at a larger scale network, I still couldn't find, there was still quite a bit of variability within the clinical cohorts across the 6 different psychiatric disorders that I showed you. And so then I thought about this a little bit more and was like, okay, can I look at a different scale? So if I reduce some of this variability at a given scale, can I then find greater consistency? And to do that, I went back to some of our basic building blocks of looking at genes. In particular, I've become interested in 22q11 deletion, which is one of the largest known genetic risk factors for schizophrenia. I think about 25 to 35% of people with this deletion end up with a diagnosis of schizophrenia. On the flip of that, if you have a duplication, it also appears to be protective against schizophrenia, which really kind of indicates perhaps there's some kind of specificity. So this was really exciting for me, particularly when you look at group level results, which is shown here. The top row, this is from the Enigma group. The top row is schizophrenia, and the second from the bottom is 22q11, but most importantly, the bottom row is 22q11 with psychosis. And you can see that the schizophrenia and the 22q11 with psychosis are remarkably similar in terms of their cortical thickness atrophy, at least at a group level. So then I thought, okay, if it's similar at a group level, will I also find the same amount of variability, or will I find greater consistency by leveraging this genetic risk to try and understand the variability? And this is in collaboration with Carrie Bearden and the 22 Enigma Consortium. And this is very much preliminary data with just a subset of the results, but I just wanted to highlight it to kind of give you a flavor of the ways in which I'm thinking about normative model. And so what I found is that I find using the normative modeling approach that I showed, I find higher overlap in the 22q psychosis group compared to controls in 22q in general, but the overlap still doesn't exceed 30%. So I guess, again, this brings me back to the same question about what do I do with all this variability? Even when I think across different scales, I'm still finding variability within the clinical cohort. And so something that I've personally been interested or thinking a lot about is that in the context of biological psychiatry, we need to be thinking about time and context in order to be understanding psychiatric disorders. And for me, a path forward in this way is trying to really incorporate deep phenotyping alongside big data. And so I think normative modeling has been paralleled across, developed alongside the use of big data, but we need to also find some kind of way to match this with deep phenotyping to really understand. And this would also adopt a transdiagnostic approach, I think. The other thing I've been thinking about a lot is by the time we get someone in a scanner, we only get one single pinpoint in time, and really we need to be thinking about the lifespan to really understand a disorder. And so I think, I was inspired today in the halls today, and I'm sure I will continue to be inspired of all the different applications of how we can be using normative modeling, and I'll hear a couple more talks today. And with that, I would like to thank a huge team. I tried to actually write everyone's individual name, but you wouldn't be able to read a single word. It really takes a village to do this kind of work, and so thanks to maybe some of the people in the room who share and contribute to this work. Thanks.